Assalamu alaikum and very good afternoon. Respected chairpersons and learned audience, I'd like to invite to my presentation. Today, my topic is what I thought and what I had done. I am Dr. Khondoker Asaduzzaman from Asgarali Hospital. Let us see my case. A 48-year-old gentleman came with chest pain for 6 months. Risk factor was type 2 diabetes mellitus. ECG was non-specific changes in antiolets. Echo showed no regional one motion abnormality, having good LV ejection fraction. And he was diagnosed a case of chronic stable angina, and we planned for CAG plus minus PCI. Let us see the angiographic view of these patients. First of all, in the left system, you can see here, there is a diffuse lesions involving the LED and very tight lesions near total occlusions in the distal or terminal part of the LED, and also there is a very tight lesions at the mid LCX, though it is a poor caliber LCX. And LED also is a poor caliber. And you can see here in the left system, right system, there is a very tight lesions at the PLB, and it is a 99% lesions. And what should be the next plan? I planned for only POBA for all 3 vessels. And I think that I was in the balloon angioplasty era, that is in 1972. And I tried to negotiate the LED with the support of balloon. Filler FC wire was used, and I took different size of balloon for sequential pre-dilatations, that is POBA, all through the LED was diffusely diseased, and starting from 1.25 balloon to 1.5 balloon. And you can see here just sequential ballooning. And just after LED, across the L6 at similar technique and with the similar balloon. And I did the POBA to the L6 and LED successfully without any residual complications and residual stenosis. Let us move to the right side. Here you can see here, I try to engage the right coronary artery by using the EBO catheter with the help of long guide wire and the back end of the long guide wire. And so on the right side you can see, I just check whether I engage the catheter rightly. And you can see here, catheter is coaxially aligned with the right coronary artery. And then I proceed to complete my vision. And I did successfully. POBA was done successfully, and there is no residual significant lesions. So I thought that my job is done. And when I took the RCA wire and took a shot for final visualization of the right coronary system, at this time, initially, actually, I did not see any right coronary artery, just after removal of the wire. But after giving some nitrates, I could find out the right coronary artery very nicely. But important issue, if you look at the scenario of this angiographic view on the left side, you can see here, there is a ostial dissection. And when I took an orthogonal view, I saw that there is a long antegrade dissections starting from ostium to the mid RCA. And let us see what acute complications occurs during PCI. You can see here the acute complications mostly coronary and non-coronary, but in coronary, mostly we found in our daily clinical practice acute vessel closure, perforation, or equipment loss or entrapment. And in the subheading of acute vessel closure, dissection is the most common. It may be total or subtotal, it may be the coronary, and ultimately this dissection leads to the non-coronary events, that is hypotension, myocardial infarction, arrhythmia, even cardiac tamponade. So let us see the classifications of dissection. This is the Ennis LBI classification. You can see here the type 1 to type 3 classification. Type 1 and type 2, type B usually is a benign dissection, but type C to type A is a malignant. I think is a morbidity and mortality is very high in this scenario. If you look at the type 1, that is the luminal haziness only, but there is no persistence of dye. But in type 2, the linear dissection, but no persistent dye. So at this moment, I think that my case may be a type B dissection. And if you look back to the C, there is that is dissection with, the persistent dye here. And in type T, there is a spiral dissection. And in type C, E, that is the dissection, and there is a persistent filling defect. And F, that is total loss of the antegrade flow. So what could be the coronary dissection? What could be the causes? Injection with dampened pressure. Be careful. Don't inject if pressure dampened because of two issues. One is non-coaxial alignment of the catheter. Another is the osteal lesions that might be in a catastrophe in your cath labs, and this may lead to the major or dissection as well. And there are a lot of etiology of dissections, as you know, and it's a very rare is the spontaneous coronary dissection. And how should we tackle the dissection? First of all, we should think whether wire in the vessel. If yes, that is maintain wire position. The wire already in the vessel, just go for stenting. If it is wire outside the vessel, then try to negotiate the wire, and definitely you should confirm the wire in the true lumen. If it is yes, then you go for the stenting. But if it, at least if repeated attempts you fail to negotiate the wire in the true lumen, then you consider for cabbage, or even in a small vessel size in cases, in that you can consider the medical management also. Let us see my case. Here I thought that my case, the dissection was type B, so I considered initially the 3x28 balloon, and I repeated inflate and deflate, and after repeated inflation and deflation, I saw that the lesion was still persist, that is dissection was not healed totally. So at this moment I took decision that I should stenting the dissected segment. At this moment, I took a second wire, and it is kept in the right coronary sinus. It will help in different ways. It will help to repeated re-engagement of the catheter and repeated injury to the ostium. It will prevent. Second one, it will help to prevent the deformation of the proximal striate of the ostium, osteal stent. And third one, you can easily cover the osteal locations by seeing the wire position. Okay, just after finishing of my slide, you can see here the final result. And this is my take-home message is here. Iatrogenic catheter-induced coronary artery dissection is rare, less than 0.1%, but life-threatening complication of cardiac catheterization. Timely recognition and prompt bailout stenting is a feasible option and should be considered early to facilitate good outcome. Proper guide catheter selection is very important, and EVO 6 France guide catheter for RCA cannulation should not be a good choice. Balloon dilatation may not be suitable option to seal the aortosteal as well as antegrade coronary dissection. Thank you all. Thank you for patience hearing.